Good morning, everyone. Welcome to Providence Medford Grand Rounds for April. Today, we're pleased to have Dr. Ari Taheri and Michael Strobridge from our Providence GI department speaking on GERD and diarrhea. Good morning, Dr. Taheri. Thank you.
Good morning. Thank you for inviting me. I'm Ari Taheri, and this is Mike. We work as a team here, and we are running a program that, to some extent, is unique to itself. We started this program as direct access endoscopy, direct access colonoscopy, rather, and eventually with upper endoscopy. And our intention was help this large group of people who needed to be scoped with lack of gastroenterologists at Rogue Valley. As you know, the only group of gastroenterologists is gastro-consultant, and there are about 9 gastroenterologists short. So just 2 of them, very long waiting time. So, and we would get referrals from mostly primary care, internists, surgeons for doing colonoscopy as colon cancer screening, and then scoping patients with acid reflux, essentially screening for Barrett's. But this program expanded because of shortage of gastroenterologists, and we ended up seeing even more and more patients to be scoped, like beyond the screening for colon cancer, like rectal bleeding, even diarrhea, refractory reflux, dysphagia, and all of that. So this practice has expanded tremendously. We have multiple people helping us to make the program run smooth. Michael has been fantastic helping with this. We have Sarah, who is a PA. And then we have Ashley, who is a new MP with us. And typically when these patients are sent to our group, there is a pre-procedure visit that is essentially a virtual visit. Majority of the visits are by Sarah or Ashley, the ones that are really very simple. Then there are a couple of nurses who do that. Now, how we ended up with these lectures is that what to do with these patients after procedure. You're probably all aware, unfortunately, gastro consultants would not see these patients after procedure, meaning that if a patient gets scoped by our team and needs GI care, and we send as referral by primary care to that group, they decline the patient. Now, some of these are already being seen by gastro consultant or sent to us because waiting time to be seen there or to get procedure is many, many months. So to make a long story short, we decided that, okay, to some extent, we are going to treat some of these patients after procedure. And then we realized that a lot of these cases, if I talk to primary care provider, maybe they can take care of management of acid reflux. So a large group of these patients would not need to see gastroenterologists. And then we also added workup of diarrhea to this lecture. Before I start the lecture, I'll give you a little bit of background. I have been practicing gastroenterology for 37 years. And my area of expertise is mostly Crohn's and colitis. For about 15 years when I had my own practice, that's all I was doing. We were doing a lot of clinical trials and all of that. And 27 years or 29 years was actually in Fargo, North Dakota. And then I came to Medford about 6-7 years ago. We had GI clinic, a large volume of IBD cases, but clinic closed, and then we ended up restarting just essentially as direct access endoscopy, and the rest of it, as I mentioned. Also, besides this, we take care of GI consults for inpatient service at Providence and emergency room. And Michael is the one who is essentially running that. This service could be at times very busy, sometimes lighter, but super complex cases, and Michael is wonderful doing that. All right, so I'm going to start with ACG guidelines for diagnosis and management of GERD. And we show the slides, which is for you essentially if you want to review it more in length. But I would talk about some practical points when I come across these cases who are sent to us for endoscopy, and some of the take-home messages. And at the end of the day, a subset of these patients need to be seen by gastroenterologists, which gets to be a challenge where to send them. That is all there, unfortunately, because of huge shortage of gastroenterologists in the country and at Rogue Valley. Next. Now, this is a fairly simple slide. It would be really helpful for primary care providers to have these algorithm handy for them. Now, some of the practical points I bring up here is that one, how long should these patients be treated with PPI before you take it to next level? I also hear a lot of concern about side effects of PPI. Patients come to us saying that, okay, well, I improved a lot, but primary care said there are side effects of dementia, osteoporosis, things like that. So medication was stopped. So I'm going to touch base about those practical points. When a patient starts with garden variety reflux symptoms, if it's more than maybe 5 episodes in a week, they need treatment. We definitely stay away from Carafate. That treatment should be out as solo treatment and does not add anything if you use it combined with PPI or H2 blocker. Two is we do not recommend H2 blocker as a starting point. Definitely is inferior to PPI. Then three, going to PPI, any PPI you can try. The name of the game is to make sure that is taken half an hour before meal. Nexium, maybe you're okay if you take it with food, otherwise empty stomach is name of the game. And the next thing is they have to take it every single day. So you see the response because it takes several days to have a steady blood level to become therapeutic. So typically these patients should be treated at least 6 weeks, reevaluate the patient. If acid reflux is completely gone, they can try to cut it down to every other day or come off. Otherwise, they have to be on it long term. Lifestyle modification, I really try to take it easy there. You give patients a lot of guidelines they're not going to follow. So I would just make a couple of comments as far as try to avoid large meal at the end of the night, elevate the head of the bed. That's about that. Maybe if they are drink a huge amount of coffee, that might play a role. So otherwise, all kind of other diet people would not follow. Now, we talked about that, and the other thing I wanted to add here is concern about PPI side effect. Definitely, short-term use is not a concern. Long-term use, some of the studies have not been really solid, have not been large population, have not been head-to-head. So the result is really taken with grain of salt, including dementia. Osteoporosis in patients who do have other risk for osteoporosis, or if they already have underlying osteoporosis, osteopenia, again, is not a contraindication to use PPI. We see such huge number of patients who come with esophageal ulcer, a stricture, Barrett's esophagus, and of course, adenocarcinoma of esophagus, which is number one cancer in the country, and number one risk for it is reflux. So coming off PPI is not an option unless you consider patient for surgery. Now, if patient has risk factor or already diagnosis of osteoporosis, osteopenia, you probably need to do surveillance a little bit more often and treat them more aggressively, but stopping PPI and not treating acid reflux is not an option. On the next. Now, the other thing is who should be a candidate for surgery? This is at this level, really, patient needs to be evaluated by GI. Typically, going from primary care to surgery can be really complicated unless a primary care is totally aggressive managing these cases, which is nothing wrong with that. So what I would do is that I would treat these people for 6 to 8 weeks, reevaluate them. If they're still having symptoms, easily go to twice a day, again on empty stomach. If they have symptoms again, 6 to 8 weeks later, some small group would benefit from adding Pepsid 40 milligram right before bedtime because gastric pH drops significantly middle of the night and it can cause breakthrough in reflux symptoms. So adding Pepsid at the end of the night could be helpful in another subgroup. So by now you have had probably 3 different steps of treatment, each of them 6 to 8 weeks. If your patient still has symptoms, then you do need referral to gastroenterologist unless you want to work it up yourself, which would be doing pH study while patient is on PPI. And if that shows significant acid reflux, then referral to surgeon. A lot of surgeons also need motility study to make sure patient does not have significant dysmotility causing dysphagia post Nissen wrap. Now, gastro consultant is the group that does pH study and motility study. We do send some patients to them, even if we have scoped the patient, they accept to do that procedure, but not managing the patient. I don't know, Michael, do you know if they would accept those procedures requested by primary care?
That's a good question. I do not know. I assume, but I couldn't.
I suspect they would, but if they review the chart and indication is not there, they might not do it. So you do need documentation for things you have done. Now, of course, I'm not now. So this is at this step. One thing to remember about surgery is that majority of patients with these solid studies, 10 years after Nissen surgery, need to be on PPI again. So ideally, you really want to be aggressive with treatment for these patients. When you get the symptoms under control, you can definitely step down slowly and see how things go. One question is that should we go to max therapy right away, meaning that double PPI? I don't see any reason to do that. A good chunk of them respond to PPI only one a day. When should you send these patients for endoscopy? Do you have that, any of that guideline? Just try it if you can find it, otherwise, never mind. Typically, any patient who has had acid reflux long term, even if he's under control, should get scoped to make sure there is no Barrett's. And risk factors for Barrett's actually has changed significantly. So we are a little bit more aggressive scoping these people if older than 50 years old, white male with obesity, smokers. So just keep in mind that sending these people for EGD is a good idea. And then when we do the EGD, if there is evidence of esophagitis, especially grade D, I would max the treatment and bring the patient back to make sure that he's healed. These patients should stay on PPI lifetime, even if their reflux is gone and grade D esophagitis is resolved. If upper endoscopy showed ulcer, again, I manage the treatment, maximize it, bring the patient back to make sure the ulcer is healed. And a lot of times with acid, I mean, it's not the title of this lecture, but it goes with it to some extent, and that is development of dysphagia. Now, patients who do have acid reflux that is not managed significantly well, they can develop a spasm and dysphagia. So when we scope these patients, we might not see any stricture, but history of ongoing acid reflux is enough. So when I send this patient back to you, I say in my recommendation, maximize treatment. That's the rationale behind it. Now, if maximizing treatment dysphagia is still there and endoscopy has been negative, then you need referral again to GI to do motility study. Also, one brief sentence, as you probably all have heard, is that there is increased incidence of EOE, and any patient I see for dysphagia, even if endoscopy is normal, we always biopsy for EOE because that would be a totally game changer and needs aggressive treatment. Some of the treatment can be done by primary care, but if they're complicated cases, we highly suggest referral to GI before they develop lead pipe, esophagus, and all that. Anything else?
I think we touched on a lot of those about the not recommended fate.
Yeah.
No prokinetic agents.
Right. Yes, prokinetic agent is important. Mike is right. We really do not recommend that, especially things like Reglan has a lot of side effect and should not be used for treatment of acid reflux.
Talked a little bit about switching as well, so if you don't respond.
Yeah, then switching from one PPI to another, sometimes it works. Most of the time it does not. But we can definitely try that. But if there would be one take-home message, is please be aggressive with treatment to eliminate the symptoms 100% before you ask for gastroenterology or send the patient for surgery. We can always step down. You can send the patient to us anytime for procedure, but management essentially would come back to you. I do make some suggestions in my procedure note with recommendation, but feel free to get back to me if you have just some simple questions on the phone. I can try to help you with that. Is that it?
And there's just the lifestyle intervention.
Well, again, lifestyle changes. Don't be so aggressive. They're not going to follow that. A lot of patients who come with a specific food causes heartburn, then I guess they have to stop it. But scientifically, it is mostly fatty food. Acidic food in the stomach should not contribute to heartburn unless other things are going on.
we talked about safety issues, so we
Yes.
finished that one. Long-term issues, we talked a little bit about that.
Yeah, we talked about grade C and D, Barrett's esophagus. And if we find Barrett's esophagus, we really do make recommendation as far as when would be the next surveillance. And then, of course, is unusual presentation of acid reflux is really beyond the scope of this lecture, but certainly it can cause hoarseness, cough, asthma, or atypical chest pain. When these cases are sent to us, unfortunately, I cannot contribute much to treatment, but I can scope and say you have somebody with atypical chest pain, and I do EGD and grade D esophagitis that tells us that patient has had significant reflux, although not typical symptoms as we call it. It could be a silent reflux, and we can definitely make recommendation to take care of that and see if atypical chest pain resolves. Sometimes even when endoscopy is normal, if you have ruled out everything else, you have had ENT consult, you have ruled out cardiac cases, it's not a bad idea to try a course of PPI, maybe BID, for about 8 to 12 weeks, especially if hoarseness is because of acid reflux. Even if your ENT exam is normal, it might take several months for hoarseness to go away. So putting patients on PPI for 2 to 4 weeks most likely would not be helpful. I would probably try a good 2-3 months for that. Anything else, Michael?
And the last one would be touching on renal insufficiency and PPI, which seems one of those where you just
Yeah.
nephrology if needed.
Right. So Michael is correct about renal insufficiency. Now, some patients you would see that my recommendation is follow up with primary care. These are patients who have renal insufficiency, especially also in older patients who are on a lot of medication. Is beyond the scope of this practice to figure out if it's safe for the patient to be on PPI or not. So these are the case that I said, well, follow primary care, consider PPI if it's safe, with renal problems or interacting with other meds. Anything else?
And we talked a little bit about nutrient deficiencies, so I think that should be good with that one. And
Yeah.
so,
Okay, any question here?
Yeah, just a couple. One of the things in primary care that we end up seeing is we might have a new patient or someone who's been taking a PPI for maybe 10 years. They got started on a long time ago, maybe never had a scope. They've not had any symptoms for quite a long time. Is that someone we could consider discontinuing the PPI and seeing how they do? That's one
Well,
part of the question. And the second is, should they have a scope if they have a long history, even if it's been well controlled?
yes, they should definitely be scoped at least once. As far as treatment, yes, you can try that. You can either stop it all the way or make it every other day and see how that works. A small percent of patients can come off it completely. My experience is that is unlikely to take them off medication unless there has been significant change in lifestyle, or especially obese patients when they lose weight. A lot of times acid reflux is improved significantly. But don't be surprised if they have to be back on medication, and then they would have a lot of questions for you. Is safe to be on PPI? I think is important to discuss with the patient what happens if acid reflux is not under control.
Okay, thanks. Another question, it might be a little off topic, but some of patients who present with epigastric pain, not clearly reflux. They end up getting tested for H. pylori, and I think there's at some point there was a thought that that might be protective against against adenocarcinoma of the esophagus. Is that the case, or do you know anything about that?
Yes. Well, I mean, just to start with, in part of these patients who come to us, although it was not the intention, but we do a scope fair number of patients just for epigastric pain. And if you look at management of it, if I scope a patient for epigastric pain, even if it's 100% normal, almost always I biopsy for H. pylori. If H. pylori, and if you're seeing the patient in the clinical setting, you have not had um, any scope, you cannot get the patient to be scoped, or there are no other indication for the scope, you can definitely do a stool test for H. pylori. Now, should you treat it? Yes, because H. pylori is carcinogen and is number 2 cause of peptic ulcer disease, and then is carcinogen for gastric cancer. Would epigastric pain go away with H. pylori? Different studies show that if there is no ulcer, getting rid of H. pylori in majority of cases would not get rid of abdominal pain, epigastric pain. But there is still some patients who respond to it, so I would treat that. As far as impact on adenocarcinoma, it decreases it slightly, but still your main cause for esophageal adenocarcinoma is Barrett's esophagus that comes from acid reflux. Does that answer your question?
Yes, thank you.
Sure.
That's all the questions for now.
Okay, so we are going to go to this next slide. And again, intention of this slide is helping primary care sort out patients who truly need to be seen by GI. And although it was not intention of our program when we started, but we do see fair number of patients with diarrhea. And I always discuss it with the patient, or even before they schedule the patient, that if we find any major pathology, be aware that gastro consultant would not see you. So you might end up going out of town for GI care. So it is important. And if you see something like that mentioned in the pre-procedure note, that's the reason. When we see a patient for diarrhea, if I'm doing EGD and colonoscopy at the same time, for sure I would biopsy duodenum for celiac. As you all know, celiac is very common, and we would never put people on gluten-free diet empirically, because there is a test available to rule it in or rule it out. Your upper endoscopy with biopsy of duodenum is number 1 test to check for celiac. As long as patient is not on gluten-free diet, a lot of patients do that on their own. So we want to make sure that they're on regular diet before I biopsy. You're seeing a picture of here as far as what we're talking about, diarrhea. Now, second question in here is that if you're not doing upper endoscopy, when I see a patient who comes for diarrhea, even if colonoscopy is normal, I always biopsy, mostly for collagenous colitis is the same as lymphocytic colitis. If you're concerned about IBD, you do need abnormal colonoscopy. And then for majority of patients who have diarrhea, I try to get into terminal ileum. We biopsy terminal ileum for Crohn's disease. Even if it's normal looking mucosa, you can still have ileitis, and most common cause for ileitis is Crohn's disease. Now, this is what we do. If biopsy comes back as collagenous colitis, again, we can make some recommendation for primary care treatment, which would be essentially budesonide for eight weeks, right, Michael? Yes, with 8 weeks with a taper, there would be a struggle to get insurance approval. So, and then looking into patients who are prone to side effects of budesonide. This is a little bit too much for a primary care, but we might not have any other option. Now, this is what we do. But when patient comes to you for diarrhea, few practical things, or maybe I'm sure most of you already practice that. Number one is list of medication. That's the most common cause. Taking supplements can also contribute to that, and go through the list of questionnaire. And the other thing would be no, let's go back.
Oops, sorry.
Go back there. No, next. There. Now, one thing that might come handy to you is that if patient has diarrhea at night, diarrhea that wakes up the patient, that is usually an indication that we need more investigation. Microscopic colitis, IBD, infection, medication induced. So that might be a little bit of help to screen them at the beginning. What is your next one?
It's alarm features.
Yes, these are the alarm features when you are handling diarrhea, so that it would make you think that, okay, well, maybe there is something else going on, and try to refer these patients to GI. Age 50, especially if patient has not had colonoscopy, that's super important to do that because it could be the first presenting feature of colon cancer. Now, what is the next one?
Family history. Go to the next slide.
Yeah.
That's where to start the workup.
Okay, now this is the intention of this lecture. Again, lactose intolerance is common. If you're suspicious for that, I do not recommend any testing. Spend 5-10 minutes with the patient, give them a specific instruction for only 48 hours. If they're lactose intolerant, you would get significant improvement in the symptoms. And at that point, then you ask the patients to reintroduce dairy products one at a time, maybe say for 2 days. A few ounces of cheese every day, see if you get the diarrhea back. Then stop cheese, try it with milk, so on and so forth. So patients who are lactose intolerant, they might tolerate some of dairy products or some not. And this way we can find out which one, and then using lactate pill, 3-4 pills with each portion of dairy products can be very helpful. One thing to remember about lactose intolerance, it could be just temporary. A majority of the time, if patients get some sort of infection, even a stomach flu, the level of lactate enzyme in the lining of a small bowel is pretty low. So any type of infection, sometimes long course of antibiotic can diminish lactate level, and patients can become lactose intolerant, but this might improve on its own. Then we talked about celiac, either upper endoscopy, otherwise do a celiac panel. The panel we order here does have IgA as part of it. If it's not, keep an eye on it. Then we look at CMP and the rest. Our concern is, of course, if patient is significantly anemic, that might lead you to further investigation. Thyroid function test is important. And then, of course, the history here is important. Now, you see a lot of GI dysmotility causing diarrhea or constipation in diabetic patients. So tight control is important. Some of these diabetic patients develop fat malabsorption. So I would not really do a stool fat on these people right away, but if there is history of travel, do OMP. When you're concerned about infectious diarrhea, check a stool WBC. That could be a good indicator if it's positive that you need more workup. We talked about celiac, colon cancer, cholecystectomy, post-cholecystectomy diarrhea usually subsides after a while. Same thing with bowel surgery, but if it doesn't, then cholestyramine is an option. But there are a lot of issues with cholestyramine. You have to keep in mind that it can cause malabsorption of certain medication, especially thyroid hormone. So just run it by pharmacists. A lot of times they have to space that from other medication patient is taking. Now, if your patient comes with complaint of a stool looks greasy, they have difficulty flushing it in the toilet, then you think about fat malabsorption. Now, there could be many different causes for it. Diabetes is one of them. If they have had history of pancreatitis, pancreatic insufficiency is another cause. We do see sometimes bacterial overgrowth with no underlying cause, but if patient has had surgery before, then that would be another concern. If you're concerned about fat malabsorption, the best test to start is random stool fat. If random stool fat is high, then you typically need referral to gastroenterologist. If you want to be a little bit more aggressive with it yourself, then you can ask for 72-hour stool for fat. That's a little bit more complicated with diet instruction. They have to take 100 grams of fat orally for that test and all that. And then laxative use, we do see that, especially in some patients with eating disorder, they try to lose weight. Anything else?
I think the only other one I'd say is if they get constipation, we see a significant amount of overflow.
Yes, that's a good point. Patients who have had chronic constipation or even advanced colon cancer, they can get overflow that looks like diarrhea. Is hard to believe, but it does happen that in spite of all the public education, patients can come not have paid attention for colon cancer screening, and we find almost obstructing colon cancer that presents with diarrhea as overflow.
That should be everything.
That's all I have. Any question here?
Thank you. We'll give it a minute to see if we have any other questions. I think if I understand, if I'm seeing a patient with chronic diarrhea, I think you mentioned doing the calprotectin, the fecal calprotectin. Was that right? Just part of the workup?
Well, I did not include
Oh,
fecal
okay.
cal there, but definitely it can be done like any other test in medicine. When we order a test, we need to know what to do with the result. Now,
Right.
if fecal cal is slightly elevated, it can cause a lot of confusion not to do what to do with it. But for sure, if fecal cal is significantly elevated, is usually suggestive of significant inflammation or infection in GI tract. So if you're using that to screen these patients and say who needs to go to GI, yes, you can do that. But for most patients, they do have other alarming signs or symptoms that needs referral to GI, including nocturnal diarrhea, weight loss, and things like that. But you can definitely do fecal cal if needed. When we see these people in GI clinic, if colonoscopy is normal, then we can definitely do fecal cal to help us to say, okay, well, this is highly concerning about IBD. Then we run a small bowel with MR or CT enterography and all that.
Thank you. Do you have any comment on breath testing for small intestinal bacterial overgrowth?
Michael, you have something to say?
We've been finding significant difficulty with actually obtaining that. Especially after they were working on it at one point. I don't know if they've found the person that we actually go through. Certainly, I think once we get to the end of it, and if you're thinking SIBO, then it makes sense.
Well, we don't, Michael is right. And I also, I mean, I have been burned and I was wrong in my diagnosis. But in patients who do not have any risk factor for it, then I would go after breath test when I have ruled out everything else. Now, if you have had a patient who has had the small bowel surgery, resection, partial small bowel obstruction on and off because of adhesion, patients with Crohn's who are not responding to biologic and all that, yes, there is more use for it, but just de novo, I'm not, maybe I should be, but is not one of the basic elements when I work up patient for diarrhea.
Thank you. I do not see any other questions. We might give it one more minute.
Now, again, we are around, Michael and me, if you have any question that we can help you with, and just at least guide you so you can get rid of some of the basic stuff and slim down patients who do need to go for further GI workup. That's the whole intention here. Feel free to call us and we go from there. I usually in these lectures, I give my cell phone number to all the providers. I'm at 701-200-9613. I do not check my messages on Epic all the time, but this is my cell phone number. Just text me, and I would eventually get back to you. Might not be right away. So we can certainly do some brainstorming, and I can do my best to make your life a little bit easier.
All right, thank you. I'm not seeing any other questions, so thank you for your very informative presentation. And
of course, and I appreciate all the effort from Michael who put all these slides together. And please get back to us. We would like to get a feedback to know how we did. And for future sessions, if you want to invite us, if is anything specific you want us to talk about. And also your feedback is going to help us because when we have lectures with these topics for other groups, we can try to tweak it to make it more useful.
great. Well, thank you very much.
Sure. Have a great day. Thank you, Linda.
Yeah.